Today, we're going to break down the mechanics of breathing from lung volumes all the way to disease patterns, connecting structure, physics, and physiology into one system. Let's start with lung volumes and capacities. The most basic unit is tidal volume. This is the amount of air you inhale or exhale during normal quiet breathing, roughly 500 milliliters in an average adult. It represents baseline ventilation, not maximal effort. Now, no matter how hard you exhale, you can never empty your lungs completely. The air that remains after maximal expiration is called residual volume. This volume prevents alveolar collapse by maintaining positive pressure and keeps gas exchange continuous between breaths. When we talk about vital capacity, we're referring to the maximum amount of air you can exhale after a maximal inhalation, essentially the usable volume of the lungs. It reflects lung compliance, respiratory muscle strength, and thoracic mobility. Then we have peak expiratory flow, which measures the highest flow rate achieved during a forceful exhalation. This reflects airway resistance, not lung size, and is especially important in obstructive conditions. Now let's move to spirometry and flow volume relationships. Spirometry measures dynamic lung function. The most important parameter is FVC, forced vital capacity, the total air exhaled forcefully after full inhalation. Within that maneuver, we measure FEV1, forced expiratory volume, in 1 second. The ratio FEV1 over FVC tells us whether airflow is obstructed. Normally, this ratio is around 0.75 to 0.85 in healthy adults. If it drops significantly, it suggests airflow limitation. The flow volume loop graphically represents airflow against lung volume. In obstruction, the expiratory curve becomes scooped due to airway collapse. In restriction, the loop is narrowed because total lung volume is reduced, but shape remains relatively preserved. Next, the A to A gradient, or alveolar to arterial oxygen gradient, measures the difference between oxygen in the alveoli and oxygen in arterial blood. It helps determine whether hypoxemia is due to ventilation problems or diffusion/perfusion mismatch. A widened A- gradient suggests impaired gas transfer across the alveolar membrane, or V/Q mismatch. Now let's talk about gas exchange and diffusion. Oxygen and carbon dioxide move across the alveolar capillary membrane via passive diffusion, driven by partial pressure gradients. Oxygen moves from high partial pressure in the alveoli to lower pressure in pulmonary capillaries. Carbon dioxide moves in the opposite direction. Diffusion efficiency depends on surface area, membrane thickness, and pressure difference. According to Fick's law, oxygen diffusion is more vulnerable to impairment because it relies heavily on surface area and membrane integrity, whereas CO2 diffuses about 20 times more easily due to higher solubility. Finally, let's analyze disease patterns. In obstructive diseases, such as asthma, the primary problem is increased airway resistance due to bronchoconstriction, inflammation, or mucus. Air gets trapped, residual volume increases, FEV1 decreases significantly, and the FEV1 over FVC ratio drops. Expiration becomes prolonged and inefficient because small airways collapse prematurely. In contrast, restrictive diseases involve reduced lung compliance or limited expansion. In pulmonary fibrosis, thickened interstitial tissue reduces diffusion capacity and total lung volumes. In obesity, excessive chest wall mass mechanically limits lung expansion. Here, both FEV1 and FVC decrease proportionally, so the FEV1 over FVC ratio is normal or even slightly elevated. Total lung capacity is reduced, and diffusion may be impaired if the alveolar membrane is affected. So when you integrate all of this, breathing is not just moving air. It is a coordinated interaction of pressure gradients, muscle mechanics, lung compliance, airway resistance, diffusion physics, and perfusion matching. When any one component fails, the pattern of lung volumes, flow rates, and gas exchange parameters reveals exactly where the problem lies.